I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Not everything is perimenopause. I can't tell you, I am the most excited person that we are seeing hormonal change for women over 40 coming into the limelight. I am the most excited person about this. And yet, what happens when things enter the limelight is that often a pendulum of knowledge, treatment, etc., really swings the other way. And I want to call this out before it becomes a problem, because I think that thinking everything is perimenopause, which it's not, we're going to go through that, what else could it be, is going to make you feel frustrated with your engagement with medicine. It's going to make you feel unheard, and we might go down this total rabbit hole of solutions for you that you don't actually need. So I want to talk that through a little bit. There are forms of bias, and this is my favorite thing to talk about, honestly. I find it so fascinating that the way that our brains work when we get new information, the way we cling to old information, the way that our brain prioritizes information. Well, so-and-so said that, and so-and-so is famous, and so therefore they must be right. Our brain does this crazy thing where we categorize information based on where it came from, how long ago we heard it, and it changes the way that we interpret new things, right? It changes the way that we look at the world. And one of the biases is, the thing that we're learning right this second, we start to see it everywhere. So have you ever had that happen where someone points something out and you're like, I never noticed that before. And then, you leave your house and now there's 8 Lamborghinis on your street and you had never noticed even one before. That is a particular kind of bias. And I think when we start to bring certain types of health conditions into the limelight, it's common that we start to see it everywhere. And this happens with practitioners too. And I call it out with them as well, where they go to a seminar and that seminar is on some, chronic condition that we never see in practice or see very rarely in practice. Now, all of a sudden, they feel like all their patients have that unique disease because they just learned about it. So you're doing the same thing if you're, now seeing perimenopause in every waking moment of your day. It's likely because it's the most recent thing that you just learned about. And maybe you are seeing it with some, celebrities or people that you trust. And that actually starts to propel this bias where now you're going to see your experience through this lens of this new information that you have. And you might be right. Okay. So let's, we just have to hang here that, bias, calling out bias doesn't mean you're wrong. It's just that we want to ensure that we're not misunderstanding the circumstance because we're seeing it through a particular lens. And if everything in your Instagram feed right now says that everything that happens to you over the age of 40 is perimenopause, and maybe even my Instagram is guilty of that because I am talking about that quite a bit, doesn't mean that's the only thing that can happen to people over 40 that causes fatigue, depression, sleeplessness, right? So that's the purpose of us having this conversation today is what else can it be? And I don't want you to get frustrated if you're seeking medical support and they won't acknowledge the hormone component to it because there might actually not be a hormone component to the way you feel. And I mean, the other piece there is that like the treatment for perimenopause is there's not that many options. And so we actually want to make sure that we haven't ruled out something that like has reliable solutions for it, and that we don't put you in the perimenopause box when you don't need to be there, because the solutions we have to offer you are not that robust, right? Like we don't have a million options. And so you don't want to be put in that camp if you don't need to be, because getting put in that camp is just acknowledging that your body is in a life phase that we're probably not going to treat you for it a ton anyways. So let's make sure that there isn't something else going on. So let's start with that diagnosis criteria or diagnostic criteria for perimenopause, because you may feel like it's your hormones, but if you are not having some of those outward symptoms, it's hard for us to diagnose you with perimenopause. And I am the first one to say that waiting until you've missed a period or until your period starts to change is probably doing you a disservice. We do know in the literature that some of the biochemical changes of perimenopause are happening 5 to 10 years before you start to see menstrual irregularities. But clinically, that's where we flag you, right? So there's this big disconnect. Like at the molecular level, there is some unraveling of your hormones that happens maybe 5 years before it ever shows up in a menstrual cycle. Can we feel that? That's something we don't know yet, actually, right? We don't actually know if the slight uncoupling that we experience between our brain and our ovaries, because that's really what's happening, is this really tightly regulated system starts to separate a little bit and they start to become uncoupled, where your ovaries suppress some of the brain hormones, and the brain hormones control the ovarian hormones. That as each of them start to be less effective, they start to act a bit more independently. And that's why we don't get these beautiful 28-day menstrual cycles, and why we get these different menstrual cycles. But that uncoupling is probably happening 5 years before it shows up in your period. So what does that mean? Like, do we know that? Do we feel that? And that would be a lovely place for us to spend some time in the research, and certainly would be much more validating for women than it is that we wait until they do have menstrual irregularities to call them perimenopausal. It'd be nice if we could call you perimenopausal sooner, but we really can't. So that actual diagnostic criteria to formally call you perimenopausal includes changes to your menstrual cycle length. That's the real thing we're looking for. The change needs to be more than 7 days to formally satisfy that criteria, meaning that if your cycle previously was 28 days, that you are experiencing cycles that, could be as short as 21 days or, 37 days kind of thing. That's that formal diagnostic criteria. Now, you may have other symptoms or other things that start to creep in that's going to give us some confidence in that diagnosis. Hot flashes, for example, vaginal dryness. That would maybe give us some signals that your estrogen levels are falling and maybe not getting picked up in that next cycle the way we want them to be. But that's the formal diagnostic criteria. Now, what happens with the press with perimenopause is, now that we're bringing to light that this is a cause, I'll say, of why women don't feel that great in their 40s, that we now have many, many women who are saying, see, it's my hormones. I knew it was my hormones, but now my doctor won't listen to me. But if we really inquired with them about what's happening with their menstrual cycle, they're still having regular menstrual cycles. Now, maybe parts of their hormonal experience is more pronounced, because lots of things do increase, like PMS, like heavy bleeding, as we enter our 40s. And that is not perimenopause per se, right? Like, that's not necessarily perimenopause, but there's still hormonal symptoms. But the Venn diagram of life for women in their 40s is pretty complicated. So when the symptom that you are coming to your doctor with is fatigue, brain fog, I don't feel quite like myself, and like, for all intents and purposes, the rest of your hormonal symptoms are fine and your period is still regular, like I said, there is a huge checklist that we should be going through before we label that as hormonal. So I just want you to come into those appointments and feel, when you are trying to engage that conversation about perimenopause with your doctor, that they're not withholding something from you by not formally giving you that diagnosis. And even I have casually referred to myself as perimenopausal. I've only had 3 late cycles in the last 2 years, and they are all after weightlifting competitions where I've had to weight cut. And so I don't actually meet the diagnostic criteria for perimenopause. I can't use it. I can't use the term. So, and that's okay, right? I don't need the term. So I need you to be okay with that too, right? That you may not be there quite yet. That doesn't mean you're not having hormonal symptoms. It doesn't mean that you're not having symptoms. We're not discounting your experience. We just want to label you properly so that you get the right treatment. I've always loved that term, diagnosis is therapy, and that comes from Dr. Matthew Leonardi from the endometriosis clinic that I have a great relationship with. The path to getting better starts with accurate assessment. So we don't want to call you perimenopausal if you aren't, because then you're on a path that is not going to support you. So let's talk about a few of the things, and I'm not going to spend a ton of time going into each of the conditions that you need to rule out when we're talking about the symptoms of the what else could it be, right? Each of those things could be an entire podcast on their own. But I do want to run through what assessment would look like for me if you came in and you said, well, my primary symptom is fatigue, right? And I think it's perimenopause. I would want to walk you through what do I think, or what do I need to consider in order for me to land at perimenopause? What needs to be ruled out first? So we'll start with fatigue, and that symptom's tough. And if you are struggling with fatigue, there are a couple things you need to do to go into that appointment feeling more confident about having that conversation and helping your doctor, because the biggest challenge when we're doing a history taking in patients is when we ask them a question and they're like, oh, I don't know, or, oh, I've never thought about it that way. Because now we're going to have to watch you for a little bit for us to better understand what's happening. And so if you're struggling with fatigue, some of the things you need to pay attention to is there a cyclical nature to it? And I don't mean menstrual cyclical, although that can also happen. I mean, is there a ebb and flow to the fatigue? What do you notice about the fatigue? Is there a time of day? Is there a time of the week? Is there a time of the month? Are there things that you've noticed that improve it or make it better? Are there times where you forget that you are fatigued? Are there times where it's notably worse? Fatigue is a really tough symptom because many, many chronic conditions have fatigue as a symptom. And there's lots of cool research about why that is. Does our brain have this sort of I'm sick experience when you're struggling with inflammation or chronic disease? This is why we see fatigue in patients with autoimmune disease. And it's your brain is well, we don't know what's wrong, so go lie down. So certainly if you have fatigue, we need to big picture make sure that there isn't another concern going on. But I would say for the average person in their 40s, some things I'm curious about is obviously anemia is a big one. And we probably want to be a bit more stringent about these numbers than we have been in the past. We like to see ferritin over 40 as a number to make sure that iron deficiency isn't the cause of fatigue. And that's, so if you've had a little bit of blood work done in the past, you could maybe go look at that. But ideally, we want a more comprehensive iron panel done if you are struggling with fatigue and we're unsure about your iron. We probably want to expand that assessment and not just look at ferritin and hemoglobin at face value and look a little deeper. Partly because a ferritin can also be elevated if you have inflammation. And so there are a couple of other tests. Transferrin saturation would be the one I would want to see that helps us differentiate between low iron and high inflammation, etc. So certainly the anemias, and B12 deficiency is not very common, but that technically should be thrown in there as part of an assessment for fatigue. We also should be ruling out hypothyroidism, which is common at this phase of life. If you've had hypothyroidism, or if your thyroid's ever been, I'm going to say in air quotes, watched, whether that was during pregnancy or at any other time in your life, in your 40s is where we may see that transition into hypothyroidism. And so those are some basic labs that really should be done if your presenting symptom is fatigue. Now, we certainly also want to look at the other things that influence energy regulation in the body, like fueling. So the number of women that are dieting in their 40s, like, do you know what the number one side effect of dieting is? Aside from being cranky, it's fatigue. Fatigue is the number one side effect of calorie deficit. And so if you're dieting, and even if you're not dieting consistently, right? So, and maybe you don't even identify with the word dieting, but it's like, well, when my partner works nights, I eat a bowl of popcorn for dinner. Like, even that, right? And so when our fatigue is inconsistent, when we don't see or feel the impact of that bowl of popcorn dinner in the moment, but if we project that over the course of a week, you're really under fueling over the course of the whole week. And you don't need to be losing weight to be in a calorie deficit some of the time, right? And so when we're looking at fatigue, I always come back to fueling with patients, and they never believe me that that's part of the issue. But when we look at their overall day and week, you know, if you're that person who's like, I'm exhausted every day by 2:00, but you ate like a Baby Bell cheese and a couple of crackers at 11:00 for breakfast, like, this is why, right? It's not perimenopause. It's because you're under fueling. So that is a real one that needs to be assessed. And then, of course, your sleep habits and your sleep in general. And yes, sleep starts to unravel a bit during perimenopause, but also our sleep hygiene sucks. Right? We go to bed too late. We don't take care of ourselves. We generally try and get by on as little sleep as possible. Like, there's an award to be won if you're awake more hours of the day than everybody else. So those things need to be looked at as a real basic if you have fatigue. And only when all of those boxes are checked off would you move to that next level to say, well, maybe it's something else. So I know we all want to be considered to be unique and special, but the vast majority of fatigue, at least in my practice, can be mopped up by looking at anemia, fueling, and sleep. I know that is not sexy. That is not a sexy solution, but honestly, that's where the vast majority of problems actually lie, is in those three areas. When we start to get into the brain fog piece, it's hard because brain fog and fatigue are like deeply connected, right? So all of the things I just mentioned also need to be assessed and mopped up before we can blame your brain fog on your hormones. But there are also other things that show up in this phase of life that can start to cause some brain fog. For example, if you maybe are starting to have some high blood sugar or struggling a little bit with diabetes or pre-diabetes, that's definitely one of the causes of cognitive change or brain fog in our 40s, 50s, 60s, and beyond. That definitely is one of the things that needs to be ruled out. So if you have a really strong family history of diabetes, that would maybe be something that I would want to look into if you were struggling with some cognitive change, or if you were feeling like you were struggling with some brain fog. And then there's the burnout side of things. And burnout also does cause fatigue. Again, when your brain feels like you don't have the resources to cope with the day, it's foggy, right? Like brain foggy, and it's tired. It's that whole idea where it's like, if you don't have what it takes to get through the day, like, go lie down. So if you're struggling with brain fog and you're overwhelmed and having some symptoms in that regard, we certainly need to consider burnout as one of the differentials, as well as, depression. And I was going to say just depression, but what I mean by that is like depression not caused by perimenopause. So I certainly don't mean just depression. But if you have depression, or if you're struggling with a mood disorder, you will also struggle with some brain fog and cognitive change, as well as fatigue. So again, there are other conditions that need to be ruled out that are not perimenopause. Perimenopause might put pressure on your mood, but if you primarily struggle, if you've always identified that you struggle with a mood disorder, in your 40s, you may start to see some overlap between perimenopause and depression, but we want to make sure that we're labeling the right thing. And if you're struggling with brain fog, that is something to consider. One of the others that I've added to my list of things to look for when we're struggling with cognitive change is to look at the potential for ADHD diagnosis in older women. We were missed, I say we as a group because I have ADHD, we were missed as a group generally being assessed at a young age, and typically we've created adult lives for ourselves aside from having to fill out passport applications that maybe don't put a lot of pressure on ADHD, and yet in our 40s that can start to resurface. And so I certainly want to look at that. Again, that like meal timing, fasting, dieting, calorie restriction can definitely put pressure on cognitive function. And then also, looking at your cardiovascular health. So, generally women in their 40s have decent cardiovascular health. We're not, like, if we match up against men in their 40s, their cardiovascular health is worse than ours in our 40s because we're protected by our cycle, and it's still happening generally. But if you are on the verge of having high blood pressure or having some cardiovascular disease, that can also affect your cognitive health. And then the last one, which you've all heard me nag about many, many times, is sleep apnea. So if you are struggling with fatigue and cognitive decline, and then your sleep is also affected, and you don't even need to know that you have sleep apnea. Like, nobody wakes up in the morning and says, "Ooh, I think I had sleep apnea last night." This is why you need a sleep study. But sleep apnea is another cause of daytime fatigue and cognitive change. And so again, if we're starting to have a more robust assessment of what's going on with you, and we're struggling with daytime fatigue, and we've started to check those boxes, it's not anemia, it's not this, a sleep study to rule out apnea is really important. And then lastly is the sleep. And there are a lot of things that will impact your sleep that are not hormonal. Again, with sleep, I want you to track it. You need to pay attention to what aspect of your sleep it actually is that you're struggling with. Is it falling asleep? Is it staying asleep? Are you urinating in the night? And this is a hard one because we all do that thing where when you wake up and then you're like, I might as well go to the bathroom. Did that wake you up? Or did you wake up and then you're like, well, I might as well so that I maybe don't have to go later? But nocturia, or urinating overnight, is one of the things that does start to surface in our 40s and 50s. And part of that is related to hormone change for sure. It also can be influenced by our nutrition, by other aspects of our health. And so if you're up in the night and it's urination that's actually driving you out of sleep, that's a very different conversation than being, like, air quotes, just perimenopausal. So those are the things that need to start to be ruled out before I can get confident that we're talking about just perimenopause. And all of those other things actually have, I don't know if it's as like more significant or just as significant long-term health outcomes or consequences if we don't deal with them, right? So when you go into a doctor's appointment and you are hell-bent on what you think you have, and they start to invite other possibilities that they want to screen for, it's not because they're not listening to you. It's because those other things, whether it's sleep apnea or prediabetes or iron deficiency, that if those things get left unchecked, you're going to be very unhappy 10 years from now, and your health is going to be much poorer. And maybe for some of those things, we cross a line where we can't reverse it, right? And so we actually do want to do our due diligence and make sure we check all of those boxes. And so sometimes we can find that patients get frustrated with us when they come in and they say they have this and we want to screen for celiac, and they're like, I don't have that. And we're like, you only know if you don't have it if we do this blood test. Or they'll say something like, I'm pretty sure it's not my iron. We're like, cool. We want to be very sure it's not your iron. And so doing that other assessment and ruling out the other things is an incredibly important step. I don't want to say that perimenopause is a diagnosis of exclusion, because it's not, right? It has really defined diagnostic criteria. The problem is that you probably feel some symptoms before you meet that diagnostic criteria. And that's why we have this little window of frustration, 5 years before you start to skip periods. Just hang with your doctor in that moment and make sure that it isn't something else. Because if we've checked all of the boxes and there's nothing else, you're eating perfectly, you're sleeping perfectly, you don't have sleep apnea, you don't have iron deficiency, we don't think you have ADHD, we've checked every box, then we can comfortably sit together and say, well, you're 46, maybe you're having perimenopause. But we can't jump there. And you don't want us to, actually. So not everything is perimenopause. Lots of things are worsened by perimenopause, but not everything is perimenopause. And so as you're cruising the internet and you're noticing the very loud conversation about hormonal health, I want you to remember that just because it's the last thing we talked about online doesn't mean it's the most important thing. It's still just in the mix with all of these other things that might be causing your symptoms in your 40s. And I really want you to get assessed so that we make sure that we actually follow the treatment direction that you need, because that is going to be what makes you the happiest.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.